this works. Well, this doesn't quite work, but let me see if it's. So these are some of my disclosures. And my other disclosure is that I once was in a body box with Param and Mario Castro. It wasn't a pleasant experience once we shut the door, but I did survive, and our total lung capacity has since been diminished. But always good to think about Param. I'm in communication with Param quite frequently about a lot of academic things, but also he shares pictures of his kid's wedding and of his parents, and I share equally with our family. So I consider Param to be a close friend, not this close, but in general. So when I think about asthma and how it's evolved over the last several decades, we've come a long way in the last 60, 70 years. It used to be just a disease that was characterized by bronchoconstriction. And then in the 1980s and 90s, we recognized it was a disease of inflammation. And then about 20 years ago, we started to look at phenotypes of asthma and recognize that there were differences, and asthma is a heterogeneous disease. That being said, there were all sorts of cluster analyses and phenotypic studies. I didn't find that it really helped me in any way in terms of management because we didn't really have any therapies at the time that allowed us to choose specific therapies. In the last 10 to 15 years or so, though, we've really started to approach an era where we utilize precision medicine approaches. And we start to think about what type of asthma does each patient have in terms of endotype, in terms of mechanism. And that's really where we are today. When I think about phenotype versus endotype, the phenotype is the outward manifestation of disease. In general, phenotypes refer to what can a patient tell you about themselves? Are they tall? Are they short? Are they black? Are they white? Are they fat? Are they thin? Whereas the endotype, the patient can't really tell you what their endotype is unless you do some type of evaluation of the underlying mechanism of disease. And the outward manifestation of that can be expressed phenotypically, but usually we identify the endotype or the mechanism of disease based on biomarkers. And we recognize that there are specific biomarkers. And the reason we do endotyping is so that we can personalize our approach, because every patient has a little bit of a different type of asthma. It's a very heterogeneous disease, and we recognize this heterogeneity. But our goal is to try to maximize drug response by giving the right drug to the right patient at the right time. And the way we endotype, we've long recognized that just in the last 10 to 15 years is through utilization of different biomarkers. And McMaster has been one of the pioneers of biomarker evaluation in terms of identifying the role of sputum, which I would say is not done well anywhere else but at McMaster, which is a bit of a problem. We do it okay at National Jewish in Denver. It's done well at University of California, San Francisco, but most other places don't take full advantage of sputum measurements and sputum eosinophil measurements, which really reflect what's going on at the tissue level. We take it one step further at National Jewish when we do our evaluations, because we do a lot of investigative bronchoscopy to help us identify what type of asthma a patient has. Not that sputum isn't useful, but with bronchoscopy, you can also get a sense of the anatomy of the individual, whether they've got vocal cord dysfunction, whether they've got anatomic abnormalities, whether they've got mycoplasma or chlamydia, on top of just getting the sputum for eosinophils and neutrophils. It's pretty good what we have now in terms of biomarkers, and we're way ahead of where things are in the COPD world. But really, we only have a couple of good biomarkers. And I think we need to do better. There's a lot of work going on identifying, whether or not periostin, that's sort of come and gone. DPP4, dipeptidyl peptidase 4, was a biomarker of IL-13 activity. Eosinophil peroxidase, urinary bromotyrosine. These are all useful tools, useful biomarkers to help try identify what type of asthma a patient has. And the goal is really to identify a specific endotype, although ideally we'd like to move beyond that and identify a picture of what's going on in an individual on multiple levels, perhaps even at a genotype level, and get more of a pharmacogenomic approach to our management. So when I think of asthma and its complexity, I think about all these different pathways that are involved. And I think that's one of the most important questions to ask, again, is what type of asthma does the patient have? And when you look in the literature, there are oodles of these, what I call asthma confusograms, with all sorts of confusing arrows going in different directions, with all the different cells, whether it's mast cells or eosinophils or neutrophils, different T cells, whether it's Th2 cells, Th17 cells, Th1 cells, or ILC2 cells. All of these are important cellular elements. The most recent confusogram that I find helpful, but which is way too confusing, is from Guy Brussel's New England Journal of Medicine article from a year ago, where I reviewed that actually for the New England Journal of Medicine. And the initial iteration was too simple, and there was so much more complexity. Then when he started adding more cells, more arrows, more biomarkers, it became even more confusing. But it's a reality. Now, the reality is, though, however, that this is just our two-dimensional depiction of what's going on in the airways. It's not, it's a reflection of, to some degree, of the reality of what's going on, but it isn't complete reality because it's much more complex. We have arrows going from the airway epithelium to Th2 cells directly or indirectly, ILC2 cells, Th17 cells, with different cytokines, particularly the alarmins up top there, IL-25, IL-33, and TSLP. But we're still learning about all of their different functions, and we're trying to understand how much redundancy there is in the airways based on all of these different cytokines and the epithelial alarmins in particular, which seem to be directing things upstream. But all of these different cells, all these different cytokines are potential targets in asthma management. And we've done a pretty good job. Starting back in the late 1990s, we started targeting leukotrienes, and even before that, histamines, and then targeting IgE, targeting IL-5, IL-4, and IL-13, and now more recently targeting TSLP. We don't have a lot that target some of the non-type 2 pathways, although there were studies in the mid-2000s, early 2000s, targeting tumor necrosis factor, for instance. Etanercept was studied by Mike Berry and colleagues, which actually showed some efficacy at that time. And then you can target all the different cells that we have here. There have been efforts to target the prostaglandin D2 receptor with CRTH2 antagonists. There have been efforts to target the airway epithelium as well as the airway smooth muscle, which is well depicted here. But all of these are potential targets that we can go after in patients with asthma and with severe asthma. That being said, historically, all we had up until about 15 to 20 years ago were just inhaled corticosteroids and long-acting beta agonists. So that brings us to where we are now with asthma guidelines. And the latest set of 2022 asthma guidelines, I suspect there's going to be a 2023 set coming out imminently, but these guidelines really suggest a escalation from inhaled corticosteroids to long-acting beta agonists to use of long-acting antimuscarinic agents, with a goal of assessing in patients with severe asthma their phenotype, as well as factors contributing to the underlying disease, as well as comorbidities. And this is a key component of how I approach asthma. Before you start patients on a biologic, and there are recommendations to start different biologics, including anti-IgE, anti-IL-5, anti-IL-4, and anti-TSLP, it's really incumbent upon us to try to evaluate what else could be going on that's contributing to asthma, whether it's adherence, whether it's comorbidities, whether it's other factors, and also figuring out what type of asthma it is. The next question, though, beyond these therapies, is really what gaps remain in our goals of asthma management. And one of the questions that we have now, right now we're at the stage where we're asking, well, we have patients who are not controlled, we want to get them into control. But what about getting disease remission? What about disease modification? These are relatively new buzzwords, new concepts that we're starting to utilize in patients with severe asthma, with the major definition of remission and disease modification being a state in which patients are well controlled over the course of a year, having sustained improvement that can either be spontaneous or as a result of some type of biologic intervention. We generally think of these different domains: exacerbations, and oral steroid use, normal lung function, daily symptoms, and type 2 biomarkers, cell nitric oxide, eosinophils in the blood, and sputum, and IgE. If we can achieve normality of all of these, then we might be able to achieve remission. Unfortunately, with the drugs that we have now, we've only been able to demonstrate maybe 30 to 40% of patients are able to achieve some degree of remission. So that's our goal in the future. And I think that hopefully that giving the right drugs to the right patient will result in greater achievement of remission. Now, what's my approach? This is my big picture general approach. I try to treat everyone with a personalized approach, trying to figure out and asking what type of asthma does this patient have? Because your asthma is going to be very different from your asthma. It's going to be very different from your asthma, both from a cellular level, from a genetic level, and from a response to therapy level. So I want to try to identify what type of asthma a patient has based on their phenotype and endotype. And then I want to treat with the most appropriate therapy based on the underlying mechanism. And I also think it's critical to evaluate before that for comorbidities and optimize adherence. Now we have these therapies. Historically, up until a year or two ago, we had omalizumab, we had the anti-IL-5s, pembrolizumab, reslizumab, and benralizumab, and then dupilumab, anti-IL-4. And then in the last year and a half, we've had approval of, there we go, anti-TSLP therapy with tezepelumab, which has emerged as a bona fide therapeutic option that targets upstream at the epithelial level and targets some of the alarmins. Now, other novel therapies that are in development include anti-IL-33, anti-IL-17, anti-IL-6, anti-M1 prime, anti-GATA3 DNazyme. There have been TLR9 agonists, antibiotics, JAK inhibitors. All of these are potential options. There's been a couple of failures recently. The CRTH2 antagonists or the prostaglandin D2 antagonists. Those were oral therapies that failed to achieve efficacy in phase 3. And then some of the anti-IL-13 therapies, including lebrikizumab and tralokinumab, also failed in phase 3. Whether those were because of the mechanism, whether it was because of the study population, whether it was because of study design, still remains unclear. But these are all bona fide novel therapeutic approaches that will complement the therapies that we currently have. So what can we achieve with all of these biologic therapies? Well, overall, our goal is to try to achieve some degree of remission. And certainly we're on our way there. We're able to reduce exacerbations. We're able to reduce steroid dose and side effects. We're able to improve symptoms and quality of life. And hopefully we'll be able to achieve at some point disease modification to prevent asthma over the long term. And that's one of our major goals, is to achieve all of these things. So the challenge, though, is figuring out which therapy is the right therapy for each patient, and how does one choose between biologic agents? So in general, we utilize biomarkers to help us predict therapeutic response. Some biomarkers are better than others at predicting. Some are good response biomarkers. We need better biomarkers than what we currently have, but we generally want to phenotype our patients with the goal of giving precision medicine to help measure different biomarkers to determine endotype and phenotype. I'll start off just with a quick review of what we have now, and then we'll talk about the future and where we're going. So one of the key advances in the last 8 years or so has been the approval of therapies that block IL-5 or its receptor, and that block eosinophils and eosinophil function. Here's a nice plump eosinophil here. You can see with its granular proteins, eosinophilic cationic protein, major basic protein, eosinophil-derived neurotoxin, eosinophil peroxidase. All those can cause eosinophilic inflammation and tissue damage. And we have 3 excellent therapies, mepolizumab and reslizumab, that bind IL-5, and benralizumab, which binds the IL-5 receptor. And with these therapies, we've been able to reduce exacerbations and improve outcomes. Early on, the mepolizumab data that led to its approval included the Hector Ortega study published in the New England Journal of Medicine, which showed that you could get about a 50% reduction in exacerbations with 100 milligrams of mepolizumab given subcutaneously. Not a huge amount of improvement in terms of FEV1, but a slight improvement in lung function. Elizabeth Bell's study in patients who were on oral corticosteroids demonstrated a 50% reduction in oral corticosteroid dosing in patients treated with mepolizumab, while still reducing exacerbations by about 50%. So this was very exciting, and I think was really game-changing in terms of how we approached our patients with severe asthma. Reslizumab was another therapy. It's administered intravenously. It too was effective, reducing exacerbations by about 58%. It had a greater improvement in lung function. It's dose based on body weight, and its major limitation is that it's administered IV. And so it's not as convenient, and I think it hasn't really gained the uptake that it possibly could have gotten. Unfortunately, the studies with reslizumab given subcutaneously failed to demonstrate efficacy in the 200 milligram dosing that was studied in that patient population. Benralizumab was another therapy, which I think was a key advance in patients with severe asthma. Both the Sirocco and Lima studies, Gene Bleeker and our friend, the late Mark Fitzgerald from BC, demonstrated reduction in exacerbations in patients with more than 300 eosinophils. And this too was a huge advance. One of the advantages of this therapy was after the first 2 doses, it could be administered every 8 weeks. So that's another big advantage of this therapy. And then Param study that was published in the New England Journal of Medicine 6 years ago demonstrated significant steroid sparing efficacy of benralizumab, including demonstrating a 75% reduction in oral corticosteroid dosing versus 25% reduction in steroid dosing with placebo, a 50% difference, while we're demonstrating a 70% reduction in asthma exacerbations in patients with a eosinophilic phenotype. So this was, again, exciting new data. When dupilumab was evaluated and first approved for atopic dermatitis, the question was this broader blockade of type 2 cytokines improve outcomes? And with dupilumab, it demonstrated playing a role in terms of blocking the IL-4 receptor and therefore blocking both binding of IL-4 and IL-13. Now, we know that blocking eosinophils has efficacy. As we demonstrated, when you get rid of eosinophils, you can reduce exacerbations. What about the role of IL-4 and IL-13? Well, IL-4 is involved in B cell trafficking and production of IgE that's involved in the allergic response. IL-13 is involved in trafficking of eosinophils, mucus production, airway hyperreactivity, and production of exhaled nitric oxide. So perhaps giving anti-IL-4 receptor therapy would be effective. And indeed, it has been shown to be effective. The first study by Sally Wenzel and colleagues published in the New England Journal of Medicine 10 years ago now demonstrated significant reduction in exacerbations compared to, this was loss of asthma control and exacerbations. There was 87% reduction in exacerbations in this cohort. Now, in this study, patients had long-acting beta agonists withdrawn and then inhaled corticosteroids withdrawn. So it wasn't more of a proof of concept, this type of study, because in the real world, we don't reduce inhalers in order to induce exacerbations. But as a proof of concept, it significantly reduced exacerbations in this patient population. Moving on to the phase, this was also here, it improved lung function as well on top of ICS and LABA. Moving on to the phase 3 studies, that demonstrated efficacy in patients who had clear type 2 asthma, patients who had higher eosinophils and higher nitric oxide, whether a dose of 200 milligrams every 2 weeks was given, or whether a dose of 300 milligrams every 2 weeks was given. Now, the 2-week dosing is a little bit of a downside for this therapy, although it can be administered at home, but compared to every 4 weeks or every 8 weeks with some of the other therapies. But this therapy, dupilumab, demonstrated efficacy in patients who had either high eosinophils or high nitric oxide. And it was shown to lower IgE and lower nitric oxide, although it results in an increase in eosinophils, probably due to impeding trafficking through activity of IL-4 and IL-13 of eosinophils from the blood into the tissue, such that eosinophil levels go higher transiently while patients are on dupilumab. This was the lung function data with dupilumab, and you can see that there was a dramatic improvement early on with this type of therapy. And the Traverse study was a study that I read was a long-term efficacy study, which showed that patients who were started on dupilumab, whether they were started at the beginning of the study or whether they were transitioned from placebo to dupilumab, had sustained efficacy out to 96 weeks. So this is an effective therapy for a lot of patients with type 2 asthma. Now, there's most recent data with dupilumab are in the pediatric population. This was a study by Land-Bacarier, which showed that it was an effective strategy in the pediatric patient population as well. In children with type 2 asthma, again, only if they had high eosinophils or high nitric oxide, it was an effective strategy. So that's where we are now. Last 7 years, we've developed the anti-IL-5s, anti-IL-4s. Where are we going with asthma? And what's the future of asthma? Well, one of the things that we've learned over the last few decades is how heterogeneous asthma is. And we've also learned how complex asthma is. We've also learned what the role of the airway epithelium is. And that's where blocking TSLP, I showed you before in that confusogram what role TSLP plays. It acts upstream of all the different cytokines. It interacts and stimulates Th2 cells and ILC2 cells and IL-17 cells, amongst others, to produce all of those downstream cytokines. So here comes tezepelumab in the phase 2 study. Jonathan Korn published in the New England Journal of Medicine. And here we have data which suggested, regardless of the dosing utilized, now the currently approved dose is 210 milligrams on a monthly basis. You can see reductions in exacerbations on the order of 60 to 71%. So this is the phase 2 study. The rate of exacerbations was significantly reduced. But what was most notable was when looking at the broad patient population that was studied, there was significant reduction in exacerbations in patients who had high eosinophils and low eosinophils, patients who had high nitric oxide and low nitric oxide, patients who had high Th2 status and low Th2 status. So this drug seemed to work across the board, which makes sense because it affects a broad group of cytokines directed at the epithelial layer, where there's an abundance of different stimuli, whether it's allergens or viruses or bacteria or pollutants. All of these act at the epithelial layer, and TSLP seems to direct things at that level. More recently, we've seen data from the Navigator study, which was the phase 3 study, which led to the approval of tezepelumab in this patient population. In that study, which took an all-comer approach, there was a 56% reduction in asthma exacerbations over the long term. And in patients who had less than 300 eosinophils, there was still a 41% reduction in exacerbations. So this is the only biologic therapy that has efficacy in the non-eosinophilic patient population. In fact, if you look across the board, again, patients, this is from the phase 3 data. I showed you the phase 2 study, but patients who had high eosinophils or low eosinophils, greater than 300, less than 300, greater than 150, less than 150, all the different eosinophil thresholds, also all the different exhaled nitric oxide thresholds, less than 25, greater than 25, they're all achieving statistical significance. And similarly, even allergic status, also whether patients were positive or negative to any perennial specific IG or allergen, there was statistical significant reduction in exacerbations across this whole cohort. This tells you the breadth of efficacy independent of biomarkers in this patient population. Now, one of the other things that's been noted in this study was the effect it had on the different biomarkers themselves. Not surprisingly, because TSLP is upstream of IL-5 production, there was a reduction in blood eosinophils in patients treated with Tezi compared to placebo. Similarly, there was a reduction in nitric oxide levels. Not surprisingly, because nitric oxide is generally thought to be IL-13 derived, and IL-13 is one of the Th2 cytokines that's downstream of TSLP. And so there's reduction in nitric oxide as well. Lastly, there was reduction in IgE levels. This is the only biologic therapy that's able to reduce all three of these different biomarkers. The anti-IL-5s are effective at lowering eosinophils. Anti-IL-4 is effective at lowering nitric oxide and to some extent IgE. But none of the other biologics, including the anti-IgEs, are able to reduce all three of these different biomarkers. What about patients who are on oral corticosteroids? So this is a study I led called the SOURCE study. And in this study, patients who were dependent on oral corticosteroids were randomized to receive tezepelumab or placebo. And when we looked at the categorized reduction in oral steroid dose in patients treated tezepelumab versus placebo, when we looked at the proportion of patients who were able to reduce their steroid dose by 90 to 100%, you can see that 54% of patients treated tezepelumab were able to almost come off steroids completely. The issue was there was a big placebo effect. 46% of patients treated with placebo were also able to reduce their steroid dose by 90 to 100%. When we look across all the other strata, there weren't significant differences here, whether we looked at the proportion of patients able to reduce by 50 to 100% or 25 to 50% or more. There was no significant difference. And although we published these data in the Lancet Respirology this past year, it didn't achieve statistical significance. We thought that this lack of difference could be due to differences in study design compared to some of the other oral steroid sparing trials. First of all, this was a longer study. It was a 36-week study. So patients had a longer time point with which they could potentially taper their corticosteroids. More importantly, in my mind, is the fact that patients were allowed a course of oral corticosteroids for an exacerbation and still continue on in the trial. So even patients in the placebo arm who could get oral corticosteroids and continue to taper down. So that gave patients not only a longer time, but also more opportunities to taper their corticosteroids. And so we're now doing another study similar to the design of the dupilumab and mepolizumab, benralizumab study. There are 24 weeks called the Sunrise study in patients on oral corticosteroids to demonstrate efficacy. That being said, when people say, is this an effective drug for patients on oral corticosteroids? I actually think it is. First of all, there are some patients, about 10%, 10% patients from the Navigator study who were on oral corticosteroids, they did well. And when we look at other outcomes, for instance, when we look at exacerbations, there was a reduction in this oral steroid study in patients who were on tezepelumab versus placebo. When we looked at lung function in this study, in the source study, there was an improvement in patients treated with tezepelumab who were on oral corticosteroids versus placebo. And the same thing was observed with regard to ACQ and AQLQ. So the study was viewed as a negative study, but only with regard to its primary outcome. The rest of the outcomes suggested efficacy in patients who were on oral corticosteroids through tezepelumab. And that's been consistent with my view of this therapy as I've given it over the last year. Same thing with asthma symptom diary scores. Another important attribute of anti-TSLP therapy was derived from the Cascade study. The Cascade study was a study in which patients treated with tezepelumab or placebo underwent bronchoscopy before and after treatment with anti-TSLP therapy. And this study is the first one to demonstrate efficacy in terms of reducing tissue eosinophils on biopsy. When compared to prior to anti-TSLP therapy, compared to placebo, there was a significant reduction in tissue submucosal eosinophils without any effects on T cells, mast cells, or T cells or mast cells or neutrophils, which is, in some ways, it's a good thing because you don't want to reduce tissue neutrophils because it could potentially result in increased risk of infections. So this is, I think, are some more supportive data, in addition to the fact that in this study, there was a cohort of patients who underwent airway hyperresponsiveness testing and demonstrated significant improvement in airway hyperresponsiveness. This is the first therapy that shows consistent improvement in airway hyperresponsiveness in this patient population. Most recently, the most recent data with regard to Tezi was in the Destination study, which is a 2-year follow-up study. And these are patients who were initially in the Navigator study. They were randomized to go to a second year over 104 weeks. There was sustained safety as well as sustained efficacy with a 58% reduction in exacerbations. And then when we look at exacerbations associated with hospitalizations or emergency room visits over the 2-year period, there was a 79% reduction in those outcomes as well. So we have all of these biologic therapies. We have anti-IL-4, anti-IgE, anti-IL-5s, and anti-TSLP. They're all good. What we've learned over the last 20 years or 10 years or so as we've had these therapies, first of all, we're lucky. When I first started training in the 1990s, all we had were inhaled corticosteroids and bronchodilators. I remember with glee when the ICS LABAs came out, when the leukotriene modifiers came out. But before that, we were giving triamcinolone 16 puffs twice a day. I don't know if anybody other than Jerry remembers doing strategies like that here, but that's what we used to do. We used to just give high doses of inhaled corticosteroids. We used to give theophylline or aminophylline drips at the time. And now we have all these therapies that are administered variably, that are approved almost globally, and have other indications as well, because of their relative efficacy in terms of some of the other type 2 comorbidities. And what we've demonstrated is across the board, significant reductions in exacerbations, oral corticosteroid reduction efficacy, improvement in quality of life, improvement in lung function. And so we've been able to achieve quite a bit. Are we able to achieve remission? Not quite yet. We're getting there. And I think that we're still learning. I think that we need other new therapies. Now, there have been other therapies I mentioned already, the CRTH2 antagonists, the viviprine phase 3 studies failed. There's another one called GB001, also failed. There are JAK inhibitors, which are in phase 2 right now, which work upstream. I'll talk about that in a moment. There's other epithelial alarmin targets, including targeting IL-33, like itepekimab. This has demonstrated reduced exacerbations versus placebo compared to dupilumab. It's comparable to dupilumab, but interesting, it was less effective in combination with dupilumab. This is a study that we published in the New England Journal of Medicine, where we gave patients dupilumab as an active comparator, itepekimab plus dupilumab, or placebo. And we did a similar labo withdrawal and inhaled glucocorticoid withdrawal as was done in the phase 2 dupilumab study. If all we did was a placebo-controlled study, we would have demonstrated significant reduction in exacerbations with itepekimab versus placebo. But we wanted to establish whether or not there was comparable efficacy with dupilumab and whether or not there was additive efficacy. This day, I still don't understand why adding itepekimab dupilumab did worse than either one alone. But I think it can be explained by some of the complexity, the redundancy in these different pathways. And we're not quite there in terms of understanding these as of yet. There's another anti-IL-33, astegolimab, which is a IL-33 receptor antagonist. This too has been recently studied in the last year or two. You can see that there's modest reductions in exacerbations across this different cohort with different doses of astegolimab. So perhaps this will be another beneficial therapy. Blocking IL-25. IL-25 is another alarmin. Here's a murine model studies showing efficacy in terms of reducing different cytokine levels, whether it's IL-5, IL-13, or IL-17. This is very early on in development. One of the other things that we're studying now is longer acting therapies like depemokimab. This is an anti-IL-5 that's administered every 6 months. We're studying it in asthma. We're studying it in EGPA, amongst others. It's currently in phase 3. Another therapy, dexpramipexole. This is an oral therapy. It was developed for ALS, and it was found to have as an adverse effect a reduction in eosinophils. So it's being studied as well. The mechanism is still uncertain, but it's an oral therapy that seems to reduce eosinophils in a subset of patients. It seemed to improve lung function as reported by Salman Siddiqui at ERS a year and a half ago. So this is another therapy that's in development. In the US, we're part of what's called the Precision Interventions in Severe or Exacerbating Asthma Network, sponsored by the National Institutes of Health. The PRECISE network, we're studying several different options. Imatinib, which is a KIT inhibitor, anti-IL-6 therapy with clazakizumab. We're studying tavastatin, which is a G-STOR inhibitor. We're studying a JAK inhibitor, a JAK1 inhibitor, with the notion that perhaps it's downstream of all these different cytokines. We're also studying bronchovaccin, which is a bacterial vaccine. It's an interesting concept. Can we shift type 2 paradigm into to non-type 2 by giving bacterial lysate products? And another dietary supplement or medium chain triglycerides. I'm excited about the potential of JAK inhibitors because when you look at all these different cytokines, IL-4, IL-13, TSLP, they all work through JAK-dependent mechanisms. So perhaps blocking the Janus-activated kinases will play a role in terms of patients with severe asthma. So what I've shared with you today is how complex asthma is, how far we've come, but still how far we need to go in terms of potentially achieving remission. We need to try to understand who responds to what therapy. We now have all these biologic therapies that can treat patients with severe eosinophilic asthma, with type 2 asthma, and beyond. But how do we decide which therapies work best in which patients? So my general strategy is to do an extensive workup, also figure out adherence, compliance, and to endotype patients using all the biomarkers that we talked about, whether it's eosinophils in the blood or the sputum, FeNO, IgE, and I think we still need more biomarkers. No matter what kind of patient you see, you have options. Patients with allergic eosinophilic asthma, I don't think you'll go wrong treating them with anti-IgE for the allergic component, anti-IL-5 for the eosinophilic component, anti-IL-4/13 for the allergic or eosinophilic component, or anti-TSLP. One advantage that anti-TSLP has is it'll address a couple of these different mechanisms. It'll address both the allergic and eosinophilic patients. Patients with allergic non-eosinophilic asthma, well, they don't have eosinophils, so you're not going to give anti-IL-5 to them, but you can conceivably give any of the other ones. And patients with eosinophilic asthma who are non-allergic or don't respond to anti-IgE or are out of range for dosing for anti-IgE, you can use one of the other biologic therapies. But you also have to have patient discussion about which therapy is right for them, cost to the patient, as well as the payer and provider. One of the things that's lacking, however, are head-to-head studies. We don't have head-to-head studies that will help guide us for the right patients. What about the non-type 2 patients? Well, here we have much more limited options. Azithromycin has been shown to reduce exacerbations by about 40%. Bronchial thermoplasty has been shown to reduce exacerbations by 50%. And Jerry was one of the pioneers of this therapy a little over a decade ago, not to age you, Jerry. That was when I first met you. But there's efficacy sustained out to 5 years, and now we have data out to 10 years with bronchial thermoplasty. That being said, tezepelumab is the only therapy that really is effective in non-type 2 patients compared to all the other biologics. It reduced exacerbations by about 40% in the non-type 2 patients. So for that therapy, there seems to be efficacy that works pretty broadly in both type 2 and non-type 2 patients. What about targeting IL-23? So this was a study that was published last year in the New England Journal of Medicine. And in fact, IL-23, which was thought to be one of the non-type 2 paradigms, actually did worse than placebo. So that doesn't seem to be an effective approach. The key questions to ask when you're seeing these patients is the patient controlled? Are they adherent? Have you addressed all their comorbidities? And is the patient on systemic corticosteroids? These are the patients whom you should consider biologic therapy. But you always need to decide when choosing a biologic therapy, which biomarkers have been assessed. Have you identified a single dominant biomarker? Because that may guide you one way or the other. Are there other comorbidities that can guide you in terms of treatment strategies? And did the patient respond to initial biologic? If not, you should consider switching. Our goal is to get optimal efficacy. So we're now moved from a one-size-fits-all approach to a more stratified approach, which is where we are now. But our goal is to get a more personalized approach so that we can give the right drug to the right patient at the right time. So I can give you the right drug, and you the right drug, and you the right drug for your asthma. The biologics we have are effective, but our understanding is still lagging. And so we have all of these therapies that are effective, they're upstream, and they're working quite well. But we need to appreciate that asthma is also dynamic and that it varies from individual to individual and within the same individual. But I'm excited because we have these therapies, and it's because of places like McMaster that we've been developing them due to the work of Paul and Gail and Param and others that we've been able to identify novel therapies for our patients with asthma. So with that, I want to thank you. Merci beaucoup. On peut parler en français aussi. Merci à tous pour m'entendre.
Thank you. Thank you very much. And I very much appreciate you leaving us some time for questions. I don't know if I can hear any online, but if there are any here in the room. And can I just ask you something about you used the word remission, and do you mean remission without maintenance medications or remission being good control with continued medications?
Yeah, that's a really good question. I think there's a distinction there. I think one goal would be to have remission on therapy. And then the other would be disease modification, which is remission off medications. I think they're both desirable. I think before we can get cure and disease modification off of medications, we at least have to get it on medications and then figure out in whom we can taper those therapies. Maybe if we give those drugs earlier on, we could perhaps achieve disease modification. And there's a study going on now in the United States with anti-IgE, seeing whether giving anti-IgE to 2 to 5 year olds can result in disease modification in those who are at risk. And that's something that we're looking forward to seeing those results in the next couple of years.
So the corollary of that question I asked you was the duration of therapy with biologics. So if a biologic therapy is effective, what would be your opinions on how long we should use it, and is there a paradigm to guide stopping a biologic?
Yeah, great question. When can we stop? When should we stop? Should we switch ever? Those are all important questions that I don't think that we have gotten good answers about. We know from several of the studies when patients have come off of biologic therapies that many of the patients have worsened. It isn't necessarily immediately, but it can happen over months, but not in everybody. And there are some people who actually have sustained remission off of therapy. So I probably would not stop a therapy unless the patients achieve some degree of remission over the course of a year. No exacerbations, no significant symptoms, normalization of lung function, normalization of biomarkers. For those patients, those are the ones I would think about stopping. We do need to study about how to approach those patients. When and how can you do it? Should it be done with a gradual tapering? Can you just cut them off right then and there and stop them cold turkey? My general approach in those kinds of patients over the last few years has been to increase the intervals between doses. Again, in an off-label manner, I do that to evaluate whether or not a patient come off without their losing the opportunity to go back on the drug and going through all the prescription hassles that are inherent in that type of process.
There's some questions here on the Q&A. A simulated head-to-head study was conducted at one of the Harvard medicine hospitals using their real-world data comparing omalizumab, EPO, and Dupi on formulary. What are your thoughts about using real-world evidence for these comparisons when independently conducted?
I think that real-world evidence is important because it really allows us to evaluate how things work in a normal setting, in the real-world setting. That being said, there are a lot of flaws and biases when you do real-world retrospective analyses. I'm generally in favor of prospective, randomized, controlled studies that will give more information. I'm not opposed to real-world retrospective analyses, but I do think that it's important to try to do more prospective studies when feasible.
So there's another question here about the data on tezepelumab, where the person in the audience thought you said it was effective in all the outcomes in the SOURCE study, but the question is around reduction in exacerbations, where the questioner wonders, was the reduction in exacerbations in the SOURCE study significant?
It didn't reach statistical significance in that study. Thank you for that clarification. I said it reduced, but I didn't say it statistically significantly reduced.
Dr. Satya.
Thanks.
What's your name?
Imran Satya.
Nice to see you.
So just to follow on from what there has been various attempts to do indirect comparisons by doing things like network meta-analyses of things. And over the last month or so, I've been combing through all the phase 3 studies, looking at their indications, eligibility, study years, baseline measurements. So my first question to you is that, do you think that the studies that were done earlier on, so Weschler, are the same as Navigator, Asthma, source? And is that comparison?
Yeah.
You know,
So one of the issues with looking at some of those studies versus more recent studies is that they're different patient populations. Patients in more recent study, in the initial studies, they were the low-hanging fruit in a way. Those were patients who were relatively easy to enroll in the clinical trials because there were no other biologic therapies available. Now it's getting harder and harder to recruit into these clinical trials. And when we think about how hard it is to get into the most recent studies, when patients who also have severe asthma would have been eligible to get anti-IL-5, anti-IL-4, amongst others, all the different options, I think we're dealing with a different patient population. Not to mention geographically, it's harder in the United States and Canada where there's such a wide prevalent use of these biologic therapies. It's just a bit of a different era. We also have now greater utilization of smaller particle size inhaled corticosteroids. There's greater awareness of the need to do a more evaluation of all the comorbidities and address those before enrolling those patients in clinical trials.
Just to follow up on that, one of the things that I've been looking at is looking at the baseline exacerbations, Navigator, pathway, and source, comparing it to the others. And one of the things I noticed that in the phase 3 tezepelumab study, at the end of treatment for over a 52-week period, the placebo group had 2 exacerbations compared to Tezi, which was 0.8 or something like that. When you look at pathway, the phase 2b study, the placebo arm was baseline was 2 exacerbations, eligibility criteria was 2. At the end of placebo, it was 0.6. So when you compare that with your data and source, so in Navigator, it looks like in the phase 3 program that there was no significant placebo effect. In fact, we often used to see placebo effect. In fact, there was a lack of placebo effect.
Yeah.
Exacerbations stayed exactly the same. So why is it that in Navigator we saw no placebo effect on exacerbation, but in source we did?
Yeah.
And that goes against all the advancement studies that we've ever done, showing always placebo effects.
Yeah. So the source study, I think one of the things that we've observed is just with oral corticosteroids, those studies, that's if you're talking about the lack of the placebo effect that was observed in the source study, I think that was due to the study design. And I think there's tendency to overprescribe oral corticosteroids and in general. In the US, it was very hard for us to recruit because the number of patients who are on oral corticosteroids is relatively small because of the advent of biologics and because of our efforts to try to taper corticosteroids. These are all different patient populations and studies that are recruited from wide geographic areas. And so it can be quite challenging to identify some of these nuances that we see. In the same way that there was, some patient, there was no placebo effect in the mepolizumab oral steroid study. People couldn't reduce their oral corticosteroids. But in this study, because of probably duration and because of the fact that they were allowed multiple opportunities to reduce their steroids, even if they were on oral corticosteroids, even if they had an exacerbation, I think could account for that. It's complicated. It's really hard to compare all these different studies.
I'm going to have to exercise my responsibility to stay on time. And I'd like to formally thank AstraZeneca for affording the opportunity and privilege to us this morning to listen to Professor Michael Weschler share his thoughts on the management and the future directions of care of patients with severe asthma. But Thank you very, very much.